The technical team, Exicon, can you please go for countdown, please? Yeah. Yeah. Good evening to all of you. Welcome you all for this evening. We have with us the faculties from Madras Medical College. We have Dr. Professor of Medicine, Dr. Uma Devi, Madam. Really thank you, Madam, and welcome you, Madam, for this evening, the postgraduate API-ICP postgraduate training program.
Thank you,
And
sir.
we have with us Dr. Shanti, Madam, Professor of Medicine from same institution. Really welcome you, Madam, and thank you, Madam, for joining.
Yes, sir.
And we have with us Dr. Gautam, the final year postgraduate from Madras Medical College. He is going to present a case on ventricular septal defect, a congenital heart disease. We also have the other postgraduate, Dr. Jay Sundar, is also going to join and going to present and discuss about this same congenital heart disease. I request the faculties and postgraduates to take over further proceedings of this session. Thank you.
Good evening, all. Thank you, API South Zone team and Dr. Palaniappan sir, Dr. Saravanan Kumar sir, and all for inviting us to take the class. Now, I'd like to introduce Dr. Gautam and Dr. Jay Sundar, our final year PGs, and we are going to today discuss about ventricular septal defect. Actually, this is quite a simple case, like it is almost like an UG case, undergraduate case, but I think any case has to be discussed on the whole. So with this thing, I request Dr. Gautam to start the presentation.
Okay. Good evening, everyone. I'm Gautam, final year postgraduate from Madras Medical.
Not able to hear? Dr. Gautam? You're not audible. Dr. Gautam?
Dr. Gautam is there.
Not audible, Dr. Gautam.
I think his connectivity is not good. Dr. Gautam.
Screen is shared, but voice is not audible.
Now unmute Dr. Gautam. You're muted. Please unmute. Yeah, correct. Now short.
Am I audible, sir?
Yeah.
Yes, please start.
The patient was apparently normal until 3 months back. Then she developed history of breathlessness for the past 3 months, which was insidious in onset, gradually progressive, class 2 according to New York Heart Association classification. And the patient developed breathlessness when she was climbing 2 or 3 flights of stairs, and she has restricted playing with her friends because while playing she is developing breathlessness. The breathlessness is relieved with rest. There is no history of orthopnea or paroxysmal nocturnal dyspnea. Later, 1 week back, the patient developed a sudden episode of breathlessness, which was associated with a history of giddiness, which was sudden in onset. It lasted 5 to 15 seconds. It was not associated with loss of consciousness or visual disturbances. It was relieved spontaneously. It is not associated with any postural variations. History of chest pain for the past 3 months. The pain was over a left precordium. It occurred whenever the patient became dyspneic. It lasted for 1 to 2 months, dull aching in nature. It was aggravated by exertion, relieved with rest. It was associated with palpitations. There is no history of radiation or associated sweating. History of palpitations. Whenever the patient had dyspnea, the patient developed chest pain as well as palpitations. 2 minutes. It was felt to be regular. It was relieved with rest. There was no history of post-palpitation diuresis or syncope. There is no history of swelling of legs or decreased urine output. No history of bluish discoloration of skin or squatting episodes. No history of abdominal pain, abdominal distension, yellowish discoloration of eyes or urine. No history of easy fatigability. No history of loss of appetite or loss of weight. No history of fever, joint pain, or skin rashes. No history of cough with expectoration or hemoptysis. There is no history of difficulty in swallowing, change in voice, or weakness of limbs.
Dr. Gautam.
Sure.
So, in the presenting illness, the main complaint you gave is breathlessness.
Yes, ma'am.
How are you going to derive that this breathlessness is cardiac or can it be respiratory? Please elaborate on this.
Breathlessness, which is due to a cardiac cause, is usually associated with exertion, ma'am.
Okay.
And the other things which are towards cardiac cause are orthopnea and paroxysmal nocturnal dyspnea. However, this patient does not have that. And the breathlessness is associated with chest pain as well as palpitations, which are again towards cardiac cause. And there is no history of cough or fever or hemoptysis, which would direct the breathlessness towards respiratory cause. So because of this, predominantly because of exertional dyspnea, which is associated with chest pain and palpitation, I'll go with the cardiac cause of breathlessness in this patient.
Again, you can say episodic and associated wheezing indicates more of a respiratory.
Okay.
That also can be included.
Okay.
Very good. So now we are dealing, this is around 16-year-old female. Now, can you tell us in a newborn period, how will they present about the congestive cardiac failure? We will not get a typical adult. Though
Yes.
we are physicians, like we should know something about pediatrics. So tell me something about newborn and infancy. How will you make out the cardiac cause?
Okay. In a newborn, usually if the patient is, if the baby is having congestive cardiac failure, the presentation might be in the form of failure to thrive. The baby might not take feeds properly. And whenever the baby is trying to take feeds, there might be spotting on the forehead. And the baby will take feed for some time, then take a pause to breathe, and then start feeding again, ma'am. And if there is failure, there could be edema in the sacral region, which is a dependent portion in the baby.
Okay, like school-going children, how are you going to make out?
School-going children, again, their active reduce of like in this page, she couldn't play with her friends. She used to play until 3 months back, but because of dyspnea, which is coming with the exertion associated with playing, she has restricted herself from playing.
Okay.
That is one thing which could be seen in school-going kids.
Okay, the next important complaint you said was giddiness.
Yes, ma'am.
Okay, so this was not associated with loss of consciousness and it was relieved spontaneously. That is what you said. Now, can you define what is syncope?
Syncope is the transient loss of consciousness due to decrease in cerebral perfusion, which is associated with loss of postural tone, and it is usually resolved. It usually resolves within 30 to 40 seconds, and without any resuscitative measures.
Okay, what is pre-syncope then?
Okay. Pre-syncope is something which occurs slightly before syncope, like in this patient, that could be a sensation of lightheadedness, nausea, diaphoresis, which is usually not associated with the loss of consciousness.
Okay, very good. Now, can you tell me a differential diagnosis of a child or a patient coming with syncope, young children, like this age group, no? What are you going to think of?
Okay, in a school-going kid, it could be a cardiac or a non-cardiac cause. As the patient is a school-going kid, I'll think of a non-cardiac cause on one side due to an anxiety which was associated with the new onset breathlessness, because the patient has had breathlessness for the past 3 months, during which the patient never had certain symptoms. This time it was a sudden onset breathlessness, which could have triggered an anxious episode. But coming to a cardiac cause, it could be due to either an obstructive lesion or a restrictive lesion, which could cause a valvular pathology, which would cause obstructive lesion, which could have reduced the cardiac output and caused a syncope, or it could be due to arrhythmias such as a bradyarrhythmia or a heart block, which will prevent the cardiac output from occurring.
Congenital heart disease, which can present as syncope.
A coarctation of aorta can cause syncope. Critical aortic stenosis can cause syncope. And
The cyanotic congenital heart disease.
Sorry, ma'am.
Cyanotic spell also can.
Yes, ma'am. In a patient with tetralogy of Fallot, when there is a increase in the in output, and it could be associated with syncope as well as cyanotic spell.
Okay, very good. Now, next going to chest pain. Tell some cardiac and non-cardiac causes of chest pain.
Hello.
Tell some cardiac and non-cardiac causes of chest pain.
Okay, ma'am. Cardiac causes could be either a myocardial cause, which could be due to in this age group, viral myocarditis can cause a myocardial chest pain, or a pericarditis, which could be causing. And since the patient is a school-going kid, rheumatic fever could present with the carditis causing a cardiac chest pain. And if it is a valvular lesion, it could be either a regurgitant as well as stenotic lesions. Stenotic lesions, there will be decrease in output, and there will be a hypertrophy of the ventricles, which will increase the demand, and there will be decrease in diastolic perfusion of the ventricles. And in a regurgitant lesion, like if, for example, an aortic regurgitation, there will be a diastolic runoff, which will decrease the coronary perfusion as coronary perfusion occurs during diastole.
Okay, that is in detail of all the
Cardiac.
So other causes, MVPS mitral valve prolapse syndrome can cause chest pain.
Yes, ma'am.
RVH, right ventricular hypertrophy conditions producing congenital PS and all can cause chest pain. Then pulmonary hypertension again can be a cause of chest pain. Again, idiopathic pulmonary hypertension may be there, common in females and
Okay. Yes.
that is young age.
These
Okay,
are
that
important
can be
points.
included.
Yeah, VSD can be associated with PS also. No? It may not be tetralogy, but you can have
RVH,
association.
PhD,
Yes.
MVPS or other causes. Okay, that can be included.
Female, young female MVPS is always one BD you should think of.
Yes, ma'am.
Okay, next is you said palpitation, no? Next important positive history.
Yes, ma'am.
So palpitation, can you define palpitation?
Okay, palpitation is the unpleasant awareness of one's own heartbeat due to a change in rate, rhythm, or force of contraction. It could be due to a cardiac or a non-cardiac cause as well, ma'am. Cardiac causes could be either due to an arrhythmia, which is either a bradyarrhythmia or a tachyarrhythmia. Both can cause palpitations. Other than that, both restrictive as well as regurgitant lesions could cause a palpitation. But in general, regurgitant lesions are more prone to cause palpitations due to stretching of the ventricles and atria, which could increase the risk of arrhythmias as well.
Okay,
Other than
here,
that,
yeah, continue.
Non-cardiac causes, if you're coming to that, that could be endocrine causes like thyroid toxicosis and anemia as a general cause, which could cause palpitations, ma'am. And both for syncope and palpitations, we should rule out other causes like hypoglycemia, which could be a differential diagnosis for palpitations as well.
Very good. Now here there is a breathlessness with the pre-syncope, chest pain and palpitation. All this can be accounted with even with the plain anemia also.
Yes,
all this.
yes,
Then thyrotoxicosis, young female. So you should always keep all the differentials in your mind. Madam, you want to add something, Madam? Shanti, Madam?
Okay, no issues.
Okay. Then next is some squatting episodes and all you told, no? Can you tell something more about these cyanotic spells? Though we are not dealing cyanotic heart disease, maybe with that case is there, we'll go in detail. But just tell me something about these cyanotic spells.
Okay, ma'am. Cyanotic spell is an episode which occurs when there is either there is increase in the pulmonary resistance or a decrease in systemic vascular resistance, which will lead to increase in the shunting from right to left side. It usually occurs in age groups between 2 months to 2 years of age. So whenever a baby or a patient cries or is anxious and exerts, there will be increase in the heart rate, which would again increase the venous rate into the right heart. But most of the blood will be getting shunted to the left heart. As the systemic vascular resistance is lower. So most of the unsaturated blood will be going to the peripheries, and there will be worsening of cyanosis, hypoxia, and in worst cases, it could lead to syncope and seizures as well.
Even sudden death can happen with cyanotic spells.
Yes, okay.
Okay.
So how do they prevent? How do the baby or the child learns about it?
By nature, the child will realize that in case of a small kid, a niches position, or in adults, either crossing the leg or squatting, will help increase the systemic vascular resistance, which will decrease the shunting of blood from right to left, so that the more oxygenated blood will be entering the pulmonary circulation, so that oxygenated blood reaches the organs.
Okay. Now, what are the conditions where cyanosis may present at birth?
In general, all cyanotic heart disease can present at birth, but tetralogy of Fallot is usually presenting a little later, around 6 weeks of age. Other causes which could actually present at birth include admixture pathologies like truncus arteriosus and severe tricuspid atresia with shunt, either in ASD
or hypoplastic left ventricle.
Oh, yes.
Okay. Okay. So we'll go to the next. Yes, sir. Shall we continue, sir? Gautam?
Yes, ma'am. May I move
Okay,
on?
so we'll continue. So
Okay.
now we'll go back to other histories. In a 15-year-old girl who is coming with these symptoms, we'll have to ask history of rheumatic fever. No?
Yes, ma'am.
So what history you asked about that?
Okay, the rheumatic fever is something which presents around this age group, ma'am. 5 to 15 years is the
Yes,
time which
yes,
usually comes here. So the presenting symptoms in the case of rheumatic fever could be obviously fever, joint pain, and arthritis, ma'am. Enlargement of large joints, which are
yes.
involving either multiple joints and migratory in nature. Other than that, cutaneous manifestations like erythema marginatum, which is a skin rash, is a macular rash, which is serpiginous in nature, and there could be subcutaneous nodules as well, ma'am.
So erythema marginatum usually is seen in a fair-skinned individual. What
Yes,
they
ma'am.
say is our skin, no, even brown skin, it is not usual. Usually in the swimsuit distribution, it is a transient rash. And what about chorea? What is this importance of this chorea?
Uh, Korea, the thing is, other manifestations usually present by 3 to 4 weeks after inciting event, but Korea can occur after 6 months of indolent period, ma'am.
And that criteria is enough for
Diagnosing this.
yes, diagnosing.
Isolated chorea can be taken as rheumatic etiology. Okay.
Okay. So that is an important history at this age group you have to ask. So why did you ask history of easy fatigability, this abdominal pain, distension and all that? What is the importance of this history?
Okay. Cardiac failure could manifest with one easy fatigability, ma'am. There will be increase in, decrease in perfusion, and the shunting of blood could lead to easy fatigability. Abdominal pain distension is something which occurs in right heart failure, which could lead to congestion of the liver, leading to abdominal pain, right hypochondrial pain, and further on causing jaundice.
Okay. So right heart failure, like in pulmonary hypertension. So all these points are important, and the importance of this difficulty in swallowing, change in voice. What are you
This
trying to bring out?
These are basically lesions caused by an enlargement of an atrium or ventricle, which could cause compressive symptoms, ma'am. If the esophagus compressed, it could cause difficulty in swallowing. Involvement of the recurrent laryngeal nerve could cause change in voice. And weakness of limb is again a complication, which could be either due to a embolus leading to cerebrovascular accident, ma'am. An infective endocarditis embolus can occur, ma'am, as well as a
Okay.
paradoxical embolus.
Okay, continue. Please continue your presentation.
Okay. Past history, the patient was incidentally found to have heart disease soon after birth and was given assurance that it was not a major issue. The parents, however, did not follow up the disease. There is no history of recurrent respiratory tract infections, cyanotic spells, or failure to thrive in early childhood. No history suggests of rheumatic fever in the past. There is no history of systemic hypertension, chronic kidney disease, bronchial asthma, seizure disorder, thyroid disorder, or pulmonary tuberculosis. And there is no history of surgery in the past. Coming to the antenatal history, the patient was conceived as the first child out of a non-consanguineous marriage. The mother was 21 years old at the time of conception. The antenatal period was uneventful. There was no history of any illness or drug intake in the mother during pregnancy. Birth history, the patient was delivered by normal vaginal delivery. Sorry, Plum.
Continue, Gautam.
The baby cried immediately after birth, and the birth weight was 3 kilograms. Developmental history, the patient attained all age-appropriate milestones without any delay, and the patient has been immunized up to age.
Okay, now,
Shall I proceed?
so importance, can you go to the past history?
Okay.
So what disease is incidentally found out at birth, but is given reassurance? So with this, what is your impression with this particular statement?
Okay. There are certain types of heart diseases which eventually goes with the group, ma'am. So they have thought of it as a normal disease which would eventually close. Something like an atrial septal defect or even a small ventricular septal defect, muscular
Very
ventricular
good.
septal defect can close. So that could have been one lesion. Or it could have been a patent ductus arteriosus, for which anatomical closure occurs around 3 weeks of age. Other than that, if it was a valvular lesion, it could have been either a bicuspid aortic valve or even a mitral prolapse, which could remain asymptomatic until adulthood.
Okay, so recurrent respiratory tract infection, what is the importance of that history?
It refers to pulmonary congestion, ma'am. Whenever there is increase in pulmonary
Very
blood
good.
flow, there will be congestion in the pulmonary veins, capillaries, and arteries, ma'am. So this will lead to increased chance of respiratory infection, especially
So,
in school going.
okay. So, when do you call, like, respiratory tract infection is common in children, no? When will you
Yes, ma'am.
label it as recurrent? You have any idea about it?
More than 2 and 6 months, and more than equal to 4 in 1 year, ma'am.
Very good. So more than 5 normally in children, no, childhood, and these are the important things you should know, because children are common and more prone for all respiratory tract infection. So when do you label it as recurrence, you should know. Okay, others, okay. Then going to antenatal history. Please go, no, next slide.
Yes, ma'am.
Now, very important is this antenatal period, especially in a congenital heart disease. Can you throw light about it?
Okay, ma'am. There are certain illnesses in the mother which could affect the child, and particularly considering the cardiac system, if the mother has illness like diabetes mellitus, it could lead to a congenital heart disease like transposition of great arteries. If the patient
Right.
has SLE, it could cause conduction blocks in the baby. And if the patient, mother acquires infections such as the torch infections, particularly rubella, it could cause numerous congenital heart diseases, ma'am.
That's the most important thing you should
Okay.
tell.
Rubella is associated with patent arteriosis and pulmonary stenosis.
Okay. And along with that, there'll be some dysmorphisms and all.
Yes,
So
ma'am.
which trimester the infection will lead to all these defects?
Usually the first trimester, ma'am, because development of heart occurs during the first trimester.
Yeah, so that is a very important thing we should ask. So you said some drug intake, no? What
Yes, ma'am.
drugs is going to cause, which is taken by mother during pregnancy, can cause cardiac disease?
Drugs like valproate and phenytoin, anti-epileptic drugs can cause numerous changes. Valproate can cause coarctation of aorta, hypoplastic left heart syndrome, pulmonary stenosis, and aortic stenosis as well, ma'am. And hydantoin is associated with the numerous manifestations like VST, AST, and PDA as well.
And alcohol?
Alcohol is again associated with VST, AST, PDA, and tetralogy of fault has also been seen to be associated with alcohol.
So fetal alcohol syndrome. So all this, no. So we should be antenatal mothers, no. The lot of advices during antenatal period is very important, and developmental history very important for.
Any syndromic baby, it should be ruled out, because there could be associated syndromes which could be presenting with the associated mental retardation or growth retardation as well.
Oh, very good. So can you continue?
Okay. Family history, there is no history of similar complaints or heart disease in the family members. No history of sudden cardiac death among family members. And this is the pedigree chart. This patient is the first patient with the cardiac disease in the family. Personal history, the patient consumes a mixed diet and the patient has normal blood and bowel habits.
So, okay, go to your differentials.
Coming to the summary, it is a 15-year-old female with history of heart disease since birth, who now presented with class 2 dyspnea for the past 3 months, associated with chest pain and palpitation, with a recent episode of sudden onset breathlessness associated with pre-syncope. The differential diagnosis is a congenital acyanotic heart disease, ma'am. Since the patient was found to have a heart disease at birth, and there is no episode or a history such of cyanosis in the past. It could be either a valvular or non-valvular pathology. As I said, a non-valvular pathology like a ventricular septal defect or a patent ductus arteriosus or atrial septal defect will be my principal differentials. And if I have to think about a valvular disease, it could be a bicuspid aortic valve or a mitral valve prolapse syndrome.
Okay. Madam, do you want to ask?
Commonly at what age ASD presents?
That is, ASD usually presents in the 3rd decade, ma'am.
Okay. So what about her? Did she attain menarche?
Yes, ma'am. She attained menarche 3 years back.
If you are suspecting Turner's and other things, you should be asking for the menstrual history, whether she has attained or not. Okay.
Now, in ventricular septal defect, you have given.
Yes, ma'am.
So you can say, can you classify it further and tell with your history itself?
Okay, ma'am. A ventricular septal defect is something which usually presents early on, ma'am. By 2 to 4 years, the patient will develop patient migraization. But unless it is a small, if it is a small ventricular septal defect, the patient could prolong up to 10 to 15 years without any symptoms. So this could be a small ventricular septal defect, ma'am. And by small, it means the size is less than 0.5 centimeters square. and or the QP by QS, which is the pulmonary blood flow to systemic blood flow, will be less than 1.4:1. The ratio will be.
So
Hunt
maybe,
ratio.
yes, maybe that, no? A PDA, why are you thinking of PDA here?
Again, PDA and ventricular septal defect have the similar hemodynamic mechanism, ma'am. Both, if they are small, they could present in the same age group as well, ma'am. But usually, both of them, in the moderate to large size, they usually present in early on, ma'am, around 2 to 4 years.
Okay. Now, valvular bicuspid aortic valve, this is the typical age of presentation. So, what are the conditions associated with bicuspid aortic valve?
Bicuspid aortic valve is found to be associated with the coarctation of aorta, as well as aortic aneurysms as well, ma'am. And bicuspid aortic valve patient can be asymptomatic for a long time, or the presentation could be aortic stenosis or a regurgitant lesion, ma'am. But stenosis is more common than regurgitation.
Okay. Saravanan sir, do you want to ask any question?
No, madam,
Shant-
please.
Okay. So, can you go on to examination?
Okay.
Good evening on all present here. I am Dr. Jason, the final year postgraduate from MMC. Now let me continue with the examination part. So on examination, the patient was conscious, oriented, afebrile, comfortable at rest. She was moderately built and nourished, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. There was no visible thyroid enlargement. There was no external markers of infective endocarditis. And there was no high arched palate or crowding of teeth, and there were no markers of congenital heart diseases.
Oh, okay. I want to interrupt you here, Jaysundar.
Yes, ma'am. Yes.
You're just told markers of congenital heart disease. Now we have given differentials of VSD and all, no? So
Yes, ma'am.
can you tell me something about congenital heart disease and the markers and the relevance to this case and in general, please?
Yes, ma'am. So considering a VSD in mind, and to start with congenital markers such as low set ears, mongoloid slant, like loss of nasal bridge, and presence of all these in case of presence of simian crease and sandalwood, all this in case of Down syndrome. Whereas presence of webbed neck,
Wait. Now, if there is Down syndrome, so these are the markers.
Yes,
what
ma'am.
congenital heart disease will be associated with this?
And yes, ma'am. With respect to Down syndrome, we have endocardial cushion defect as well as
Very good.
ventricular septal defect.
Yes, you can have that. So that is number one.
Yes, ma'am.
Okay. Number two. Yeah, continue.
Next, yes, ma'am. Next, considering other markers could be kind of a short stature, web neck, broad shield-shaped chest, and white space nipple, and multiple nevus. Increase cubitus valgus in case of Turner syndrome, where we could again go with coarctation of aorta, bicuspid, the increased risk of coarctation of aorta, bicuspid aortic valve, and pulmonary stenosis.
Okay, very good. So that it should be in there. Then other congenital heart diseases.
Yes, ma'am. Such as with respect to VSD, again we are dealing with Patau syndrome, Edward syndrome, where in Patau syndrome again we have like the patient could have VSD, low set ears, VSD, PDA, and dextrocardia. Whereas in Edward syndrome we could have VSD, PDA, and pulmonary stenosis.
Okay. Other let's come out of VSD. Others like in ASD, what are the associated?
Yes, ma'am. So ASD and VSD both are seen in Holt-Oram syndrome.
Very good. So what are the the features? Markers.
Yes, I mean, like such as in TAR syndrome, thrombocytopenia, absent radius. Again, ASD will be there. TAR syndrome.
In Holt-Oram, what will be the findings? Absent radius with?
Yes, tripharyngeal thumb will be there.
Very good. So these are the markers you can make out. Okay, then other. Yes.
No
Then polydactyly, syndactyly again can be told.
Yes, ma'am. Again in Down syndrome, clinodactyly, syndactyly. Yes, ma'am.
Okay. So markers of infective endocarditis very important, no? In VSD, why?
Yes, ma'am. Because in any VSD associated with any septal aneurysm or VSD with AR has like high risk of ending up in infective endocarditis, and markers such as Petite Janival lesions, Osler's nodes, and rod spots, splinter hemorrhages. All these are like external markers of infant endocarditis, so which has helped us in pick it up early.
Along with pallor,
Yes,
icterus,
painful clubbing, pallor icterus and painful clubbing.
very good. So,
Yeah.
and splenomegaly, all these will point out to infective endocarditis. These are the markers. Now, because cyanosis is important component, tell me how will you differentiate whether it's a central cyanosis? Now here there is no cyanosis, but how will you differentiate central cyanosis from peripheral cyanosis? Jay Sundar? Doctor? Not audible.
Nose, ear lobes,
Yes,
fingertips, as well as lips, outer.
Not audible, Jay Sundar. You're not audible.
Some connectivity issue. Got disconnected. Will be rejoining back.
Oh, okay, okay, sir. Okay.
Hello, ma'am. Is it audible now?
Ah, yes, good.
Okay, got accidentally logged out. Yes, with respect to cyanosis, that like two types of cyanosis, central cyanosis and peripheral cyanosis. Central cyanosis, the site which can be seen in the tongue, buccal mucosa, whereas a peripheral cyanosis could be seen in tip of the nose, ear lobules, fingertips, and outer lips. With respect to central cyanosis, again, depending upon the central cyanosis is mostly due to hypoxia, whereas peripheral cyanosis is kind of stagnant hypoxia. Central cyanosis, again, there is going to be, we can divide into cardiac as well as respiratory cause, where cardiac is kind of shunting, that is right to left shunt will occur, whereas in respiratory cause, like hypoxic states. So in conditions such as right to left shunt, we basically see the cyanotic heart diseases such as tetralogy of Fallot, tricuspid atresia, TAPVC, Epstein's anomaly, and truncus arteriosus, whereas in respiratory causes such as like anything which hinders the oxygenation, that is the which hinders the entry of oxygen into the blood, such as any, be it pneumonia, be it like bronchial asthma, any exacerbations of COPD, which causes peripheral cyanosis. And there is something known as both mixed cyanosis, central as well as peripheral, which is seen in acute LVF, where there could be a mixture of both cyanosis.
Okay, yes, causes for peripheral cyanosis before we'll move on.
Yes. Peripheral cyanosis, yes, ma'am. Like since stagnant hypoxia, that is acute LVF, reduced perfusion, such as conditions such as shock, being cardiogenic shock as well as septic shock, as well as Raynaud's peripheral vasoconstriction.
Okay.
We could have peripheral cyanosis.
Sorry. Now, jaundice with relevance to cardiac diseases.
Yes, ma'am. Jaundice, again, in case of patient developing cor pulmonale and right heart failure, where it may lead to congestive hepatitis, congestive hepatomegaly, patient may develop again jaundice. And in case of left heart acute LVF, where the patient may develop ischemic hepatitis, and again it may develop jaundice. With respect to, since it's like a congenital heart disease, again there is an entity known as there is in physiological jaundice is extended in congenital hypothyroidism.
Very good.
So in congenital hypothyroidism, it is usually associated with PDA as well as pulmonary stenosis.
And infective endocarditis.
Infective endocarditis, yes.
Okay. Continue, no?
Going with the anthropometry, the height of the patient was 150 centimeter, weight was 142 kg, BMI was 18.7, upper segment lower segment ratio was 0.8, and arm span, which was 152 centimeter, and arm span as to height ratio was around 1.01.
Why did you do all this?
Yes, ma'am. So since we are suspecting congenital heart disease, so we need to rule out like marfanoid habitus,
Very
where
good.
the arm span, yes, the arm span is more than the height. So and upper segment lower segment ratio will be less than 0.8. But since the legs, like the patient has large arms and tall legs, so in such case to rule out marfanoid habitus, we did all this anthropometry.
Okay. So the tubular bones, there'll be long tubular bones, and usually arm span is more than 5 centimeter of the height. So
Right.
that is the significance of it. And what heart disease is associated with it? If there is a
Yes, so mitral valve prolapse, marfanoid.
and what else? Mitral regurgitation,
Yes, mitral regurgitation, mitral valve prolapse.
aortic root in
Aortic root dilatation, yes, aortic root aneurysm.
and suppose if a patient with a marfanoid habitus, 18-year-old, comes with a severe chest pain radiating to back, what are you going to suspect?
Yes, ma'am. So in such cases, high chance of aortic dissection, ma'am.
Very good. So all this we should keep in mind. Unless we keep this in mind, we may not look for it and may miss it. Okay.
Yes.
Okay. Continue.
To go with vitals, the pulse rate was around 84 beats per minute, which was regular in rhythm, normal volume pulse, which is all peripheral pulses are felt equally. There was no radioradial delay or radiofemoral delay, and there was no vessel wall thickening. The blood pressure was measured in supine position. In the right upper limb, it was 110 by 70 millimeters of mercury, and left upper limb was 110 by 60 millimeters of mercury. And in both lower limbs, it was 120 by 70 millimeters of mercury. JVP was not visualized. The respiratory rate was 16 per minute. Thoraco-abdominal type of respiration. Saturation was 98% in the room. Temperature was 98.4 degree Fahrenheit.
Now you said no radial previous and radiofemoral delay. So what is the delay for carotids, radial and femoral? It's very important, no? Congenital heart disease.
Normal, yes, ma'am. Duration of conduction is 30 milliseconds for the pulse to be felt in carotids, whereas it is 60 milliseconds to be felt in brachial, and 75 milliseconds to be felt in femoral artery, and 80 milliseconds to be felt in radial artery. So physiologically, there is going to be in femoral-radial delay. First, the pulse will be felt in femoral artery, followed by radial artery.
Very good. So it depends, no? I think it is humanly possible only for beyond 30 milliseconds. Less than that, we will not be able to assess the difference. Okay.
Yes.
Coarctation of aorta, unless you look for it, we may miss it. So these are the important things you should know. So, madam, shall we proceed, Shanti, madam?
Yes, madam.
Yes. Please proceed.
Yes, so going with systemic examination proper, CVS inspection, the chest wall appear to be symmetrical in shape. Trachea appears to be in midline. Apical impulse is visible in the left 5th and 6th intercostal space, just lateral to the midclavicular line. There was no precordial bulge, no visible pulsations, no apparent chest wall or spinal deformity seen, and there was no surgical scars or sinuses.
Okay, now what is the
Apical
important?
impulse? You just say the down and outermost. Occupying 2 spaces, you can say. That's always better. You say the definition is down and outermost. Okay. That place you can say it occupies. Okay. That way you have to say. Okay.
Okay.
And second is what is the importance of this precordial bulge? No, it is a very important component in a younger individuals.
Yes, so precordial bulge can be appreciate especially in ASD where the before which occurs before the costochondral fusion. So there will be in case of RVH, since it has occurred before fusion, so precordial bulge can be visibly appreciated.
Oh, so it gives us a clue. One, it is in a pediatric age group, and it is for a long time for this to develop. No, precordial bulge. Okay, now this deformities you told, no, chest wall deformities. Can you just
yes, so chest wall deformities with respect to syndrome, for example, in Turner's or in its male counterpart Noonan syndrome, it could be like an broad shield-shaped chest, whereas in pectus excavatum is seen in Marfan syndrome and also Noonan syndrome. And pectus carinatum could also be seen in Marfan syndrome. Whereas even in Marfan's diagnostic criteria, the pectus carinatum is given more weightage than pectus excavatum.
Very good.
It is also in the seen in homocystinuria, it can also be seen in pectus excavatum.
So very good. So that is the importance of seeing for all these deformities. Okay. Going
What
to the
about spinal deformities?
yes.
Yes,
Back,
ma'am. So,
front, you told back.
straight back, yes, ma'am. Straight back syndrome, where there is loss of thoracic kyphosis. So it is, yes, ma'am, associated with yeah, it is associated with split memory. S2 splitting of S2 will be there in straight back syndrome, and there will be restrictive lung disease also.
Can
Restrictive
hear
lung.
murmur also. What
Yes, ma'am.
murmur is here?
ASD, yes, ma'am, like differential for ASD, ma'am.
Systolic murmur. You can hear with the straight back syndromes.
Syndrome.
Okay. And what diameter will be less? AP diameter will be less again.
Okay.
Very, so you should know about this chest wall deformity. Second is localization of apical impulse. No, when there is a, this is a normal teaching for all cases. No, if there is a tracheal deviation and apical impulse, you should see in the both sides of the chest whenever you are palpating also. Otherwise, we may miss even the dextrocardia. Yes.
Yes,
And
ma'am.
second is the restrictive lung disease leading out to cor pulmonale. No, all these things will immediately come to our mind when there is all these deformities present. Continue, please.
Yes. So to going on proceeding with palpation, the trachea was confirmed to be in midline, and apical impulse was felt in the left sixth intercostal space, 1.5 centimeter lateral to the mid clavicular line, which was hyperdynamic in nature. And there was systolic thrill felt in the left third and fourth intercostal spaces in the parasternal region. There was no palpable P2, and there was no parasternal heap.
Okay, now apical impulse, down and out apical impulse. What are the DDs of a down and out apical impulse?
So down and out apical impulse to go with volume motor status, such as in valvular causes, such as in aortic regurgitation as well as in mitral regurgitations,
Okay.
could lead to eccentric hypertrophy of the ventricular muscle mass, and it again also in seen in yes, volume such as in our cases such as in VSD also.
Okay.
And also in PDA where down and out could be
Yes.
could be appreciated.
Any high output states?
Cardiomyopathies can, but the intensity will not be hyperdynamic.
Yes, ma'am. Yes, ma'am.
And your anemia, high output failure states like thyrotoxic.
Thyrotoxicosis.
Yeah,
Okay.
so all that should be in your mind. Now, can you tell me all the types of this apical impulse, no? Characters and how will you assess?
Yes, ma'am. So starting with hyperdynamic apical impulse, that could then be
We
felt.
spoke about it. Next.
Yes, ma'am. In heaving up type of apical impulse, which sustained apical impulse, but is like continued for more than 2/3 of the systole, and it occupies only a single space, ma'am. And it is suggestive of pressure hypertrophy, like pressure overload. So mostly seen in concentric hypertrophy, such as conditions such as aortic stenosis, any stenotic conditions, and again systemic hypertension, again bicuspid aortic valve. Where heaving type of apical impulse can be appreciated. Hyperdynamic apical impulse, two spaces.
We suppose. Yeah, we spoke about hyperdynamic heaving. Next is tapping.
Tapping type of apical impulse. It is seen mitral stenosis, but like it occupies only a single space.
Where you get double apical impulse.
Double apical impulse seen in HOCM.
Triple apical impulse.
Also in HOCM, and LV aneurysm also.
Very good.
Triple aneurysm. I mean, apical impulse can be appreciated.
Okay. Continue.
Yes, ma'am. So, but going on with percussion, right heart border corresponds to the right sternal border, and left heart border corresponds to the apex, which was down and out in position. And right and left second intercostal spaces are resonant to percussion. Liver tenos corresponds to right fifth intercostal space.
Okay.
Yes. So proceeding with the auscultation. In the left third and fourth intercostal space, high-pitched, soft-blowing pansystolic murmur of grade 4/6 was best heard with a diaphragm of the stethoscope. And S1, S2 was like heard murmur. It was like
okay, no problem. Continue.
Yeah. Continue. And in mitral aortic pulmonary and tricuspid area, the same systolic murmur which was radiating from the left lower parasternal area was heard in all these four areas.
So now you are basically telling it is a pansystolic murmur heard in the which areas you told?
Yes, ma'am. Yes, ma'am. Left
third and fourth.
Yeah.
Now you are telling this is by you are trying to give us an impression. It is more in the parasternal, so it is going to be VSD. I am telling it is MR or PR. how are you going to defend yourself?
Okay, ma'am. So with respect to mitral regurgitation MR murmur, it could be heard in mitral area, ma'am. One. Then associate mitral area radiating to axilla,
Very
and
good.
expiration. The murmur actually it increases with expiration, ma'am.
Okay.
And if in case of like the anterior leaflet is involved, it could be related to axilla. If the posterior leaflet involved, it could be related to interscapular region. Whereas in case of TR, tricuspid regurgitation, again, it could be heard in left fifth intercostal space, costochondral junction, where again the murmur is like best heard on inspiration, which comes with the name Cavallo sign.
Okay. Whereas here it will not vary with respiration. One
Very-
important thing. Okay,
Yes.
and it has also there is a thrill also, no? Did you tell
Yes,
him?
that
Yeah,
is-
you told
that
him.
is thrill, yes,
So,
ma'am, thrill, yes.
yeah, so that's why you graded it as
4
4
past
past 6. Okay.
Yes, ma'am.
How will the ASD murmur be heard? Now here we are dealing now because in the second and third space you can hear, no? ASD
Yes.
murmur. Tell me something about it.
Yes, ma'am. So yeah, in ASD mainly flow murmur can be appreciated, ma'am. In tricuspid, as in like in pulmonary area, ejection systolic murmur.
Very good. So it will be an ejection systolic murmur which will be heard in the pulmonary area. P2, will it be palpable? ASD?
No, ma'am. Unless pulmonary stenosis like per se is there, it can't be palpable. Only if it associated with pulmonary stenosis.
No,
P2
because
will be
of
palpable.
flow, you can have a P2 palpable, but
Okay.
it will not, other features of pulmonary hypertension will not be there in ASD. You
Okay.
can
But
have
the
a,
flow will be more on the right side, so you can have V2 being palpable without
Yeah.
pulmonary hypertension.
that's the important thing. in
RV
ASD.
hyperdynamic state is the ASD.
So you can have it. Okay. Hello, I think he's doctor.
Hello.
Yes,
Oh.
yes, continue.
Yes,
Ah,
yes. So
yes,
that is a important thing you should know. Now something about PDA. So what is a typical murmur of a PDA?
Yes, ma'am. So continuous machinery kind of.
Not audible. Doctor? Not audible, Dr. Jaysundar. Dr. Jaysundar?
Dr. Gautam, you can also take part.
No, both are not there. I think they are same thing.
Ma'am, is it audible? Hello.
Yes, yes.
Yes, ma'am. So continue. Yes, ma'am. So with respect to PDA, continuous machinery murmur is heard, ma'am, where it starts with S1, peaks around S2, and again ends in S1. So through and through, during systole and diastole, the pressure in the aorta is more than the pulmonary artery. So it that is like murmur through in both systole as well as the diastole, ma'am.
Okay, if it is a small PDA, what will happen?
Yes, so in case of small PDA, so only systolic murmur, diastolic component could not be appreciated, mainly
Okay.
systolic.
Which will be the site of PDA murmur?
Yes, ma'am. So left first intercostal space, ma'am. So infraclavicular, it's also known as Gibson's area.
Okay.
So these are the other areas you should look for. Okay.
Yes.
So you have not told about split, no? All PGs we.
Yes, ma'am. Actually, since the systolic murmur was like pansystolic murmur, it was like over the S2, not able to appreciate the split. But usually in VSD, white split is there, depending upon the size. So starting from small, moderate, large VSD. So the split is wide in VSD because there is going to be early
good.
A2 and late P2, whereas as the size progresses and as the due to increased pulmonary vascular resistance, that could be early closure of P2. So as the severity increases, the split actually decreases, and in cases of Eisenmangerization, there's going to be only single. There's a chance only we'll be able to hear a single S2.
Very good. So if Eisenmangerization occurs, okay.
Yes, ma'am.
So we can expect, no, because in adult, when they grow up in adult, so most of the time we see when the Eisenmangerization develops. So how are you going to differentiate VSD, ASD, and PDA?
With respect to Eisenmangerization.
Yes, yes.
Yes, I mean, in VSD, there is more chance of.
It will be single S2.
Yes, ma'am.
In ASD, there will be
Yes,
narrow.
with respect to split, you are asking. Yes, ma'am. So
Yes,
in ASD, yes, ma'am. So
yes.
it's going to be
Yes,
ASD
yes.
was a narrow. Yes, ma'am. Narrow and wide and fixed split, ma'am. Because with respect to inspiration, there is going to be increased blood flow to the right atrium, where at the same time, in the left ventricle, the blood flow will be less. So same opposite will happen during expiration, ma'am. So the split will be wide and fixed split, ma'am, in ASD.
That will be wide and fixed. What happens when pulmonary hypertension becomes severe and they go for Eisenmangerization?
Yes, ma'am. So in such cases, there will be early P2, and the split will become narrow and fixed.
Narrow can also move. What about PDA?
Yes, ma'am. So yes, ma'am. So in PDA again, it could be not split to normal, ma'am, narrow, and it sometimes could also be variable.
Variable, it will move with respiration, like inspiration,
Yes.
expiration, whatnot. So these becomes a very important point, because what happens as pulmonary hypertension develops, a continuous murmur of a PDA is going to become systolic. Slowly it will disappear, and there may be only this narrow split. Whereas
Yes.
in VSD, again the murmur will start disappearing. No, what
Yes,
we are
ma'am.
hearing now, like good pansystolic murmur, maybe after if there is a worsening pulmonary hypertension develops, the murmur is going to disappear. At one stage, it'll come only with a single sound, with the maybe features of cyanosis is there. So it becomes split becomes a very important component when you are going to examine the for examination.
Yes, ma'am.
Okay. Now, so
What about the flow murmur in shunt lesions?
Yes, very
Flow
important.
murmur in shunt lesions.
Yes, ma'am. So in VSD, again, pulmonary area, we can appreciate a flow murmur, ma'am. Ejection systolic murmur in pulmonary area. And also in PDA, could be again in since right to left shunt, right to left shunt, again, the pulmonary flow could be here.
So MDM will be there.
MDM is
Flow
important.
murmur in all shunt lesions, MDM at mitral area can be there.
You can
The
hear a
functional.
flow.
Functional.
Functional MDM.
MDM.
No? Yeah,
In
that
shunt
is
lesions. Okay.
okay. Other system examination was normal.
Yes, so mother system examination, RS bilateral normal vesicular breath sounds ahead, no added sounds. In abdomen, soft, no tenderness, and no organomegaly. Central nervous system, there was no focal neurological deficits. So to go with the final diagnosis, this is a case of, it could be a case of ventricular septal defect, size be of moderate size, patient with normal sinus rhythm with no clinical evidence of pulmonary hypertension, congestive cardiac failure, infective endocarditis, and Eisenmangerization.
Okay. Sir, Saravanan sir.
Should be saying congenital acyanotic heart disease.
Yes,
When
you should start like
you
that.
have to. You have to. It is a
Okay.
case of congenital acyanotic shunt lesion, probably ventricular septal defect patient. Okay.
Saravanan sir, you want to add something, sir? You want to ask some questions?
Completely covered up. It's always happening like this when you're coming for discussions. Completely
My
covered up.
God, man. No, sir, please, please. You
No,
can
whatever
ask.
I know, whatever I can ask, you're just completing and starting from basics to the advanced level
Thank you,
questions.
sir.
So there's no gap.
Thank you, sir. I think for PG discussion, no, basically, because it
Yes,
is
yes.
like everybody should know. So I thought we should cover.
Yeah, no issues.
Okay, sir. Continue. Next slide, please.
Yes, ma'am. So
What investigations you want to do? Then we'll go
Yes.
to the important slides.
Yes, ma'am. To start with, routine basic investigations such as ECG, chest X-ray, and again routine CBC, yes, ma'am. CBC early, and to confirm, in case we are suspecting congenital heart disease, in order to confirm it, we need to proceed with the echocardiogram.
Okay, this is the ECG of this patient, no?
Yes, ma'am.
So what is the finding here? Yeah, please tell me.
Yes, ma'am. So it is like to a 12-lead ECG, normal sinus rhythm. Where here in lead 2, we could appreciate P mitral, ma'am, where it's the speed is going to be like more than 2.5 millimeters, 2.5 small boxes, and also we could appreciate our biphasic RS complexes in B2 as well as B3. So just there could be a like high left atrial enlargement, and also since like in VSD in case of search of ventricular hypertrophy also. So there is a biventricular hypertrophy. We are having this RS complex in B2 and V3 when transition leads.
Transition leads. Okay, just read the next slide. You read it. Next slide.
Yes, ma'am. Yes, ma'am.
So what
So yes, ma'am, this is
ECG
the
typical finding you will get in VSD? Capsule phenomenon. What is it?
yeah.
Okay. Catch-Fractal phenomenon is the presence of a large biphasic QRS complexes in the precordial leads, predominant in the transition leads like V2, V3, V4. Ma'am. It is due to presence of both left ventricular as well as right ventricular hypertrophy.
Very good, very good. Okay. So what is this X-ray findings? What are there in this X-ray?
Okay.
Jason,
That is a
or
chest
one
X-ray
of you?
PAV of the patient.
Yes,
Yeah, yeah,
yes, ma'am,
yeah.
yeah. So this is chest X-ray, PAV of the patient with adequate penetration, normal rotation. Here we could appreciate increased some pulmonary markings in the right side, right hilar markings will be appreciated, and also left second. Like so left atrial enlargement could be like the straightening of the left atrial border is appreciated. So, and also there is a cardiomegaly when we measured, ma'am,
I
it was
think
like
it is
more than half
over-penetrated,
of the.
doctor. This X-ray is over-penetrated. It is not adequately penetrated. It's over-penetrated.
So
Okay,
digital X-ray actually, that is why over penetrate. Yeah, that is there.
Okay.
Yeah, yeah. And this is what type of apex you are having? LV, no enlargement.
Yes, ma'am.
No? That type. So what do you usually like in a full-blown VST? No, how are you going to see if it's a large VST?
Yes, ma'am. So in case of large VSD, pulmonary plethora, first due to increased pulmonary blood flow, there could be pulmonary plethora, and also gross cardiomegaly can be appreciated.
So here typically, I think before going to echo itself, we see, no, it is just mild to moderate VSD.
Yes,
with no
yes, ma'am. So yes, ma'am. So it could be around, yes, ma'am, small to moderate VSD. Since like we're able to appreciate the thrill, and it could be moderate.
Clinically also, and it is correlating with what the X-ray finding you are having, right?
Yes, ma'am.
That is the important thing you are having. Okay. So can you tell the echo about this patient?
Yes, ma'am.
The patient had a perimembranous VSD with a left right shunt, and the VSD size was around 1 centimeter. Ma'am. And the gradient was 68 millimeter of mercury with a Vmax of 4.1 meter per second. In general, in the case of VSD, the things which we look for in echocardiography are the site of the lesion, the size of the lesion, how the rims are, the location, because VSD could be of 4 types, which could be muscular, perimembranous, or inlet or outlet type. This is important because the management comes based on the type. The muscular types, 2/3 of the cases could close on their own, and the perimembranous types, 1/3 could close on their own. Whereas the inlet types, we have to intervene to ensure closure of the septal defect. And apart from that, we have to see the pulmonary blood flow versus systemic blood flow, which is known as the QP by QS ratio. This is essential because management comes based on this. When we are planning on closing the VSD, we will look for a ventricular enlargement as well as a QP by QS ratio of more than 1.5. This is seen, ma'am. Followed by which we should look for pulmonary vascular as well as systemic vascular resistance.
Oh, very good, very good. So these are the basic things which we are going to see in echo, and here the TAPSE is normal only, right?
Normal. That's
No
normal, right.
features of thing. Now, going a bit to the embryology, can you tell me about how does this VSD develop and some development of this septum? Can you tell a bit about the embryology?
Yes, ma'am. So depending upon the ideally they're initially the two tubes which cardiac tubes which join together to form a single tube, and which is differentiated into three bulges. So the first bulge is known as a bulbus cordis, and the second bulge is for the ventricle, and ventricle, and third bulge is for atrium, and the fourth one is for the sinus venosus. So to go with the first bulge, it is again differentiated into three parts. The first one is going to be the uppermost part is going to be truncus arteriosus. Second one is going to be the cordis proper. Then third one is going to be it does not have a specific name, but it's going to become the future right ventricle, whereas the ventricle proper is going to be the future left ventricle. So between this, what we have is bulboventricular sulcus is there, and this is going to be the future interventricular septum, and any defect in this septum could lead to ventricular septal defect.
Okay, very good. Types of ventricular septal defects?
Yes, so depending upon the it could classify depending upon the size, also depending upon the location. So depending upon the size, as we know, small, moderate, large, and depending upon the location, it could be supracrystal as well as infracrystal. And infracrystal is further classified into perimembranous as well as muscular. And in membranes, it could be or it could be also perimembranous. In muscular, it could be either inlet, it could be trabecular, or the outlet, that is infundibular variant one.
Okay, very good. Now, can you tell me some acquired causes of VSD?
Yes, so acquired cause of VSD in case of myocardial infarction, where that could be ventricular septal rupture. In that cases, patient could develop VSD.
Okay, very good. So the ischemic heart disease also, no, and especially in MI. So we always think of congenital, but even this point you should keep in mind. Okay, next is which is the most common type of VSD?
Yes,
Perimembranous type is the most common type of VSD, ma'am.
Very good. And which VSD closure is possible?
Muscular is the most common type.
What are the mechanisms for closure?
There will be growth of, as the patient grows, there will be growth of fibrous tissue, and there will be contraction of the muscular septum, which could lead to closure of VSD. Whereas in case of an inlet VSD, as the inlet is close to the tricuspid valve, sometimes the tricuspid septum could come and close the VSD. Whereas in case of an inlet VSD, rarely, and outlet VSD, the leaflet of an aortic valve could come and close the VSD.
Okay, so what are the associated lesions you can have with VSD?
When there is an outlet VSD, there could be a coexisting aortic regurgitation.
Very good. So you have to look for it. Yes, pulmonary stenosis can be there. Yes, yes.
Pulmonary stenosis can also occur.
So how will you? So we have come to echo now. How are you going to manage this case? What is the medical management and what is the surgical management?
Medical, as of this, considering this patient, she doesn't have classical signs or overt cardiac failure, so she might not be needing diuretics at the moment. However, since there is a septum and since there is jet going from left to right, there is a high chance of infective endocarditis. So closure is the ideal thing to be done for this patient.
What are the indications for surgery?
Okay, indications for surgery when the septal defect is not a muscular small defect which should close on its own, and when the patient's age has crossed 4 years, because ideal time of closure which we have to do is around 4 years. In this patient, she's already 10 years old and she's becoming symptomatic. And once we have found this, we have to look for indications as well as contraindications for closure. As I previously said, the indications include the presence of ventricular enlargement and a QP by QS ratio of more than
1.5. Not audible. Not audible, doctor. No, please. Yeah. Now you're audible. Dr. Gautam?
The pulmonary systolic will be less than 50% of. Yes, ma'am. Am I audible, ma'am?
Yes.
Hello?
Continue.
Hello.
Audible,
Uh,
audible.
Yes, ma'am. The pulmonary systolic BP should be less than 50% of the systemic systolic BP, and the pulmonary vascular resistance should be less than 1/3 of the systemic vascular resistance. This is important because if the systemic vascular resistance is more than 2/3, or the pulmonary systolic BP is more than 2/3, it indicates that ASN migraization is set in, and the patient is not a candidate for surgery.
Yeah, they're too late. No, even if you do the surgery, we are not going to help the patient. So ideally, we have to. So now, before going for surgical management, what is the medical management? Large VST presenting with recurrent respiratory tract infection, CCF, and all. So we have to manage medically, before going for surgery. So how will you medically manage?
Yes, ma'am. So in case of large VST, if patient is like symptomatic, we need
Yes.
to aim is to decongest the patient, ma'am. So we can go with diuretics, so that we reduce the pulmonary congestion. And yes, ma'am.
AC inhibitor.
Yes, ma'am. In order to reduce the ventricular hypertrophy, AC or ARB can be used to reduce ventricular hypertrophy, prevent
Okay.
ventricular.
Yeah. So these are medical management and then planning for surgical. In surgical management, can you just put some light on the surgical management? What are the available surgical things? Percutaneous and
Percutaneous measures as well as surgical options are available, ma'am.
yes.
If it's a muscular VSD or certain cases of perimembranous VSD, percutaneous management is possible, ma'am. If it's an inlet VSD or outer VSD, percutaneous management is kind of risky, so they go with the surgical management where they either suture the place or use a patch closure.
So it's an open heart surgery.
Open
No,
heart surgery.
that's one thing. As compared to ASD, where percutaneous is the main thing. Whereas here, open heart surgery only has a role to play.
Yes,
Okay. Madam Shanti, ma'am, you want to add something?
Nothing, madam. You can.
I think we have covered most of it about VST, and here, luckily, this lady, she's having only I think around 1 centimeter,
Yes, ma'am.
moderate.
It's into moderate.
So, what is the plan now, doctor? Where is this patient admitted, and what is the plan now for this patient?
Yeah, ma'am. The patient is actually currently admitted in cardiothoracic department of our college, ma'am.
Okay.
So they are planning for surgical closure, ma'am. Surgical closure of the VSD.
Okay. Being now there is another like the social concept of being a female, she's going to go for further, and symptoms have started. So that is why I think in the cardiothoracic they're planning for closure.
Yes, ma'am.
Okay. Saravanan sir.
Madam, completely covered, knockout.
Thank you, sir. Thank you.
Remember, neurology case extensively covered. Yes,
sir.
I forget the detailed discussion. The girl was very extensively presented. And
now she is doing DM Neuro, sir. That girl, Sita Lakshmi, her name was.
I was telling, yeah, I was telling that day you should have finished your DM neurology examination by this time.
Yeah, now she's
extensively presented.
Yeah, these two have done a good job, sir. Both the PGs, they have done a good homework, and
that's very important.
That is very.
People do a good homework, they'll be able to answer most of the questions.
Yes.
Most of the time, people coming with blindly and without anticipating the questions. That's where the problem starts.
Yes, sir.
Should be avoided by the postgraduate. They should know their knowledge expert for the postgraduate. It's very important.
Yes, sir.
Good discussion on this. Even though it's a simple case, but definitely it's a common case, and so many ways the PGs can be trapped into the problem. Yeah, there's so many ways can be discussed, and you also discussed about other differentials from the clinical science wise and the clinical conditions wise. Everything is discussed in detail. Really, thank you, madam, for discussion of this topic.
Thank you, sir. Thank you, sir.
I think no further questions can we wind up, madam, or anything else to be added?
No, sir. That's all, sir. VSD is a commonest congenital heart disease, so it's very important that they should know about it, sir. We can wind up, sir.
Yeah, really, thank you, madam, Uma Devi, madam, and Shanti, madam, for wonderful discussion on this topic. Let's just thank Arian sir for really accepting our invitation, being the part of this coming weeks of postgraduate training program. Appreciate Jay Sundar and as well as Gautam for wonderful presentation as well as discussion also. Really, I don't know who is going to come for day after tomorrow medal exam. Who is going to come from
Not
MMC?
these two.
Yes, sir. Rajvel and Deepika will be coming.
Who is coming?
Rajvel and Deepika, sir.
Deepika
Rajvel
and Rajavel. They are
Okay,
coming, sir. On Thursday, they'll be there in
I'll meet both of them there in the examination also. Really, thank you, madam, and good night, all of
Thanks.
you. Thank you.
Good
Thank
night,
you.
sir. Good night. Good night.
Thank you for the opportunity.
Yeah.
Thank you.
Yeah.